Welcome to this session with the hottest and probably broadest topic I ever seen. AI, precision medicine, and personalized healthcare in the same session. So it'll be interesting to see where we land this, since it's a topic that everybody has different views of and different interpretation of what it is. I who have the honor of moderating this is named Magnus Lejelöw, and I'm the CEO of a company trying to digitalize healthcare staffing. That's not why I'm here. I guess it's because I lead a couple of podcasts as well, and loves to be on stage moderating different topics. And today we will start with the personalized part of AI. So I have the honor of having two professors with different topics, and we'll start with Axel. So go ahead.
Great, thank you.
Your 15 minutes of fame.
15 minutes of fame, perfect. Let's see if we can manage this. Oh, already, perfect. So my name is Axel Wolf. I'm a professor and the director of GPCC, which is the one of the leading research centers internationally about person-centered care. And I was invited to talk both about AI and then also about the European standard a little bit later. Person-centered care supported by AI, what do we know? The short answer is not much, so that could be less than 15 minutes. The long version is that it's not either way. We need to know more about it, but we can't choose not to do anything about it because the future lies within, like you said, digitalization and how it will support us in the future. AI transformation, the challenge of underuse, overuse, and misuse. And I think those three words are very important because on a European level, we are afraid of underusing AI, we are afraid of overusing AI, and we are also, of course, afraid of misuse. And all of those three will happen. If we have a definition, and I will shortly have a little bit of an intro about AI, so we talk about the same thing, at least how I see it, and then we go through a little bit more into the context of health. A definition from 2018, AI refers to a system that displays intelligent behaviors by analyzing their environment and taking action, with some degree of autonomy to achieve specific goals. That means that AI is nothing new. We had it since the 60s, and I come back to it. But there is a huge amount of money in AI and the research and the development of tools in the business. So it's estimated that we increase from $140 billion in 2022 to $2 trillion in 2030. So in that sense, there's a lot of money involved and a lot in stake in this kind of field. We also always talk about if AI will take away jobs or support tasks. We know from if AI has been around for 30, 40 years, and we have talked about taking away jobs, we know from evidence right now that it hasn't happened. Will it support jobs? Will it change the behaviors of me as a doctor, or nurse, or whatever? Yes, it will. But that it will take away jobs, we aren't really sure about that. But there are figures saying yes in some areas, but we haven't seen that yet. Some of you saw maybe that Mindark, which is a company in Gothenburg, said that they will fire some of the programmers and replace them with AI. That is for me one of the first evers in Sweden. But I'm not really sure that that will go into, at least in healthcare, we won't have that challenge, I believe. We also talk about the fundamental rights, equality, equity, and we're coming back to that. AI has not a problem with it. The problem is how we build in equality and equity, or the lack of equality and equity in our AI models. And democracy, can it be used for democracy, but can it also be used for the other way? And that maybe we'll see in elections later on. And of course, one aspect that we're talking about is liability. Who is liable when we're using AI? And the new AI Act that is undergoing in the EU, they're working on it. Right now, it's the user and the user organization that in the end needs to have understanding of if the AI is working correctly. So in that sense, it's also interesting to see if that will work in the future or not. But liability is a huge problem. So why are we talking about that? And why is because data is king. We all contribute to AI. The processing power, the storage, the cloud computing, the open data, the open source, everything up till now has been around collecting data. And now the AI systems are so mature that we've seen, for example, OpenAI with ChatGPT. We are going to see the Google version Bard. We have Microsoft is OpenAI also in that sense. Facebook. I think that Meta and Facebook maybe will be the strongest contender if we talk about person-centered care, and I will come back to it. But just look at the data, 175 zettabytes. I've never ever heard about zettabytes before. It's a huge amount of data. Increased just to 2025 from 33 zettabytes. So a lot of data, and we are collecting all of us in our phones, in our pads, in our sensors. So data is really the king here. And the company, and that is really the company, because that's a huge problem that we have. As a country or as an EU unit, we don't have the data. We have some big companies that have a lot of data, and that will be a challenge for us in the healthcare setting, I believe. This is nothing new. AI in some sort, if you talk about different generations of AI, has been around for the 40s, 50s, 60s. And I have the smallest notepad here, so I can see it. But Alan Turing, you have here, for example, and Lee Samuels, they started the discussion about AI in computers. And then, of course, you have when the first computer in the 1997, Deep Blue from IBM, won over the world champion in chess, Garry Kasparov. But that's still a little bit linear, and I come back to it, because there aren't so many algorithms or rule-based algorithms that you can have in chess. But then you have a Google system that came in 2016 with Go, which is a Chinese board game. I have no clue how it works, but it should be really, really advanced. It won over the world champions in Go. But then what surprised me the most was in 2017, because before that you said that a machine can never win over a human being in poker, Texas Hold'em. Because why can't you win in Texas Hold'em? Because one of the big aspects in poker is about bluffing. So it's nothing logical with bluffing in that sense. But in 2017, the first computer won over a professional poker player. So in that sense, you see that the development, even if it's old, it has increased rapidly throughout the last 10, 15, 20 years. So some key terms, just to talk about the same thing here. We are right now talking a lot about generative artificial intelligence. These are the old slides, I believe, from, these are the older slides, but yeah, generative artificial intelligence. Not the same as artificial general intelligence. And I'll come back to it. So there are roughly 3 generations, or at least 2 generations that we have. We have good old-fashioned AI, the symbolic, and that are computers which are using algorithms where you say, okay, if this happens, then do this. And these are still very much used, and they are going to be used very much in context where it's quite linear, like triaging, or for example, if you have emergencies, for example, were very, very algorithm-based in that sense, in the decision-making. These kinds of AI system will still be around for a long time to go. But where we are right now is in data-driven, where you have a much more, where you have different data sets, where you have, for example, pictures, sound files, for example, and we'll come back to it. But where we are not, and still are not, and maybe we will never be there, is what we call strong or general. So when the AI has its own intelligence and can make own decisions and be smart in that. And that is still a long way to go. Some are quite dystopic about it. I don't know about if we ever will be there. But right now, we will be still on the data-driven approach for the new systems, and for the symbolic systems, there's still plenty of room for. Structured versus unstructured. So structures is 0, 1. So I need to tell the computer what a 0 is and a 1 is, and then they can make algorithms about that. But the cool thing is when we start to use unstructured data. So when the computer or the AI will make sense of a context. Like if the computer sees pictures of a cat, for example, and a dog, this could be structured, but could also be unstructured material in that sense. When we talk about the patient's narrative, about the story that a patient tells us, for example, a lot of that we don't have in our documentation, because we don't write about it, because we are used to having structured data like blood pressure, pulse, for example. So the unstructured data is very important if you talk about person-centered care to get into our systems. Data-driven AIs and the new generations, we talk about neural networks. And the next level of neural networks is deep learning. And the difference is just that the neural network can be one layer, and deep learning has several layers, at least 2 layers, meaning that it can compress and analyze more data in that sense. And machine learning is the way that you can automate and use deep learning and neural networks and the algorithms that you use to do your analysis and how autonomous the machine is. And there we talk about supervised or non-supervised machine learning. Supervised is that in these pictures, if you want to tell the AI what is a dog and what is a cat and make the difference, they start, and when we then supervise the computer, say that this is not a dog, this is a cat, they learn from it and they will repeat it until. So ChatGPT, for example, has been a hybrid between supervised and non-supervised. Non-supervised is that the computer learns from its own mistakes in that sense, without any supervision of a human being. And there are different levels of that. And why maybe we talk so much about it right now is that at least this is one company. There are a lot of companies with these kinds of large language models, but ChatGPT is one of the companies that also, once again, makes their service for free, because they need to have input data from us, of course, in that sense also. It's a very, very interesting model if you want to write a text, for example, that this model has challenged universities. So, for example, if you are a programmer right now and a student for programming at the university in Gothenburg, for example, you can't do any exams anymore at home, because it's so good at programming, ChatGPT, so we can say if it's the student or the program that programs. So in that sense, we need to have closed exams in a room. So in that sense, there are areas where this kind of large language models will be very, very useful. But how about healthcare? And there isn't so much evidence. This is a non-published preprint, so it's a peer-reviewed journal, but it's not published yet, at least, from Eric Topola's group, looking roughly around a scope review about 80 AI solutions that they have found, at least. So there aren't so much evidence about AI in clinic. The most of the clinical evidence is in imaging, and that's once again because it's kind of structured data. But the future of AI, and now I'm going into more of a healthcare setting, is that if you look at the future of AI, you see a lot of course, objective things that we need to do. Analysis of retinal scan, multifaceted diagnostics, tumor tissue analysis, and going all the ways to what Eric Topol in this science article calls multimodal AI, where you incorporate different data sets into your AI model. And that, of course, is very, very interesting in a lot of different disease areas. But there are, of course, challenges, like the AI is often wrong, never in doubt. So the AI itself doesn't know if it's wrong or right. The embedded biases is maybe one of the key issues that we have, because if we embed bias into the AI model, they will act on it, and I will come back to it. But also that we have a huge resistance of medical practice to change. Maybe that resistance is good in some way because we need to have mature systems. But once again, overuse and underuse, we need to have a balance there. And then, of course, you read these kinds of articles where a group had an ethical dilemma because they use AI for drug discovery, which isn't nothing new. Machine learning has been around for drug discovery for ages, but they had a problem because they wanted to demonstrate how fast it goes to design potential toxic molecules. And it took the computer 8 hours to find 4,000 new molecules that could be used for toxic agents. And what they say here is very interesting. They say we can easily erase the thousands of molecules we created with our AI. So they did that. They didn't publish the molecules. However, they cannot delete the knowledge of how to recreate them. So when the AI is out there, the problem is that everyone can then recreate these kinds or create these kinds of molecules. So this is an ethical dilemma that we really need to discuss more. But let's talk a little bit about equality, and the devil lies in the details. This is an old publication from 2019, but I just want to show a little bit what the problem here is. This is a clinical approach to triaging patients for future acute kidney injury. And in that article, they state that their model predicts over 56% of all inpatient episodes of acute kidney injury and over 90% of all acute kidney injuries that require subsequent administration of dialysis. So that's very, very good. The problem is if you look around the model they used in order to build their AI, you see that they merely use 6% of the entire population that are fed into the AI model were females, so women. So that is a big problem, and that comes from that they had a database that they received, where they could build their model on, but the database was from a database where there were very, very few women. So that is a huge problem and something that we really need to look out in the future. But going to the last slides about person-centered care, and I said it before, right now we know very little how we can support person-centered care with AI, but I think that we need to support person-centered care with AI. There are some systematic reviews and some randomized comparative trials, but I would still say that the main problem is that we still don't have the correct data to feed our AI models. Because the data that we have and the data that many of the companies right now are using are data that are from science, like blood pressure, pulse, imaging. We have a lot of data on that. The problem is that we lack data on the symptom side, the breathlessness, the tiredness, the fear, the uncertainty, because we don't document that in a structured way. And most of the models that are using data are still using data that is structured. So in that sense, we are still a long way from person-centered care, I would say. So if you want to understand more about why the patient is seeking healthcare and the motivation and goal with treatment, in order to have support in making the health plan or the care plan with the patient, you need to understand the impact that the symptoms have on the patient's everyday life. That's what I do as a physician or nurse. I need to know that. But if we don't have that in our system, we will never be able to build good AI models about that. So the last slide is just something that many of my students are asking, okay, but what about AIs in the future? And I think that the problem is, and this should be a film, but it doesn't move, is that we are creating a way of looking at the AI as a human. So we are trying to humify AI. It should not be done, I would say, because AI should be a computer. You can never have an interaction with a robot, I would say. Maybe it's a dangerous path where the robot is very, very human-like. And of course, then the question is, what is a human? And these are some of the good quotations that children gave from the very nice book Levengood and Lindell wrote in 2003. Gamla tanter lägger inte ägg. I will not translate that into English. But a body consists of innards and outwards. Innards are, for example, marrows, bones, and spleens. Outwards are often more visible and can be replaced if needed, especially on old ladies. A body is something that ends in the shoes. The body needs food to survive. Italian salad costs over 5 crowns per square meters. And the soul is like a plastic bag. It's thin and transparent and holds about 4 liters. If you would put all of those quotes a lot of times into the internet, the ChatGPT model would in some aspect also make some sense of it and start to talk about the human as a plastic bag, for example. So with that, I would thank you for listening, and hopefully we can have some more discussion later on. Thank you.
Thank you. And thanks for giving us a lot of questions as well, because you explained a lot, but you also raised a couple of concerns. So, Fredrik, let's invite you up to stage and see if we will have even more question marks or if you will sort everything out until the discussion. Tack. Let's try one more.
Next.
Är det inte det?
Nej.
Där.
Eller? Oh, no. Okay, thank you so much, and thank you, Axel, for a very interesting talk here. So the topic for my lecture here, which I was given, I didn't pick it myself, is precision health. Is that the same thing as person-centered care? I will not give you the answer. I will tell you a bit about precision health, and then please join us in the discussions and coffee breaks and so on when we can see if we can come at a conclusion. I'm Fredrik Nikolaev. I'm professor of biomedical engineering at Luleå University of Technology up north in Sweden, and I'm also the president of the Swedish Society for Medical Engineering. So just to set the stage here, I personally have not been engaged so much yet, I would say, with person-centered care or integrated care. But it's good I borrowed these few slides here from the Swedish Association of Local Authorities and Regions, SKR. So I think it's good to remind oneself what is sort of the drivers of this movement towards more person-centered care. And the way I see it is that putting primary health care, at least in Sweden, in the center, working more seamlessly between the specialized care and the primary care, and also involving the individual, the patient, as a co-creator. I think these are important aspects that I see. I also many times use this slide because I think it sort of illustrates the changes that is ongoing. And if we look at the two top to the left and to the right, again, the way I see it is that it's a lot about changing sort of the healthcare system. So the way we look at the patient coming in, for instance, to put that person in the center and not having that person going from clinic to clinic, but having rather a team coming together around that person. And also, I think the human aspects, the soft aspects about it, to focus on the person and relationship. And I think here also Axel introduced us to these things that might be difficult to put into the AI database. I will move on from here to precision health, and therefore, please take a look here down to the left, in the lower left corner, where we are going from reactive. So going more from diagnosis and treatment to being more proactive. Again, engaging the person, the individual, but how can we take more responsibility for our own health? And in the longer perspective, how can we maintain a good health throughout the lifespan? So to back up a bit here, like Axel did with the Alan Turing and so on with AI, precision health comes from personalized medicine, I would say, which later on, Barack Obama, the then president of the US, coined the term precision medicine. Nowadays, we don't talk so much about personalized medicine, we talk about precision medicine. And in 2015, when he gave the State of the Nation speech to the US citizens, he launched this precision medicine initiative. And he said, what about if we could match the unique genetic code from a person to treat that person if he or she would be diagnosed with cancer with a specific cure based on that genetic code. So that was sort of the vision. And I think it's fascinating to see, just like AI, how fast we are evolving as a society, and mankind is driving this. He launched this 2015. Nowadays, we have centers for precision medicine at Karolinska, at Uppsala Hospital, and I'm sure also in Gothenburg and elsewhere. And we are actually making benefit. This is real value for cancer patients. Now, so that's good to see that precision medicine from the launch has actually made starting to make its impact in the Swedish healthcare system. The next step, where I was fascinated, was again taking inspiration from the US, where the counterpart of the Swedish Folkhälsomyndigheten, CDC, Centers for Disease Control and Prevention, renamed one of their strategic areas from genomics and public health to become precision health. So moving on from precision medicine to precision health. What does that mean? Well, I think it means a lot, because now we don't only talk about finding the right diagnosis for the right patient and then finding the right cure or the right treatment, but it's a lot here about prevention and health promoting. So if you would stand in the elevator and need a pitch, I would say that precision health is about the right intervention at the right time for the right person and in the right context. And that goes throughout the lifespan, from birth up until the very end. What does it mean in practice? To give you an example, I think tomorrow there's going to be a lot of talk about cancer. We are very good at treating cancer here in Sweden. We should be proud of that. But we also know that 1/3 of all the cancer cases diagnosed could be totally avoided if we were focusing more on the blue left side here of the circle taken from the Cancer Foundation in the report. So the society, the community, could do a lot of working with health promoting activities. It could be reducing the use of plastic, spinning out microplastics, for instance, or making us move in a better way and not taking the car or other commuting ways. This is cancer, but it goes for a lot of different disease areas that we could promote and prevent promote health and prevent diseases if we could focus a bit more on the preventive and health promoting activities. So here, cardiac, type 2 diabetes, neurodegenerative diseases, a lot of these. But the majority, more than 95% of all the resources in the Swedish healthcare system goes towards diagnosis and treatment. A much smaller amount to prevention and health promoting. We were intrigued by this. We saw that precision health will also target several of the sustainability goals, not just the obvious one, number 3, good health and well-being, but also about equality, sustainable cities, and so on. So taking inspiration from the famous drawing by Leonardo da Vinci, we would like to address precision health on 3 levels: on the molecular level, on the individual level, and not the least on the society level. So this coincided that with a timing when I took up this position in Luleå, when the Vice Chancellor wanted to initiate 3 areas for future research at the university. We arranged an open workshop in Luleå, and we could see that more than 30 research subjects. Luleå University has around 65 research subjects. More than half of them actually showed up at this workshop and said, we are interested in precision health, but we don't know what it is. And neither did we, because there was no clear definition at that time. But we could see that we could cluster these research areas into what I just said, working on the molecular level, individual level, and the societal level. So this was, after some evaluation, selected to become a new area for Luleå University, and the acronym is PRECISE. One of the first things we did was actually to sort of define or describe what do we mean by precision health. And here you can see that it's about increasing the accuracy. So I think here is maybe a difference between person-centered care. We are talking about increasing the accuracy of, or the preciseness of different interventions at the molecular, individual, community levels. And we also want to do a lot of work in the preventive stages. This spring, we selected around a dozen PhD projects. I'm not going to go through all of them here, but we are now recruiting and hiring PhD students to these. These are all multidisciplinary research projects, so it's not only targeting one research area. To give you just a few examples of what I mean when I talk about that, this is research from my own group. With Alzheimer's and Parkinson's diseases, we are, of course, drug development companies have been working very hard to come up with functional therapies for these, and we are sort of on the limit now to get some functional drug therapies. But what we do know, even though we don't have the great medicines yet, is that these degenerative processes that start in the brain may begin up to 20 years before we see the clinical symptoms. So if you get the diagnosis of having Parkinson's disease at the age of 75, it might well have started at the age of 55. I am myself 57 years old. I would like to see inside my brain, has this already started? But we don't have the tools yet to do that. How can we do it? We are working on it. Many other groups are working on it. We are making benefit of native nanoscale molecules that circulate in the human body, so-called exosomes, extracellular vesicles, that are secreted from all cells in the body. They are so small that they can pass the blood-brain barrier that protects the brain. So we can follow them back to the brain, pick them up, actually in saliva. And now we have been working together with clinicians, physicians from India, and blinded tests. We have been able to track which patients had Parkinson's disease and which were healthy subjects. We are now bringing this into Sweden and start now collaboration. I'm actually going from here to Karolinska to discuss with clinicians there. So that is one example of where we want to sort of come up with methods where we can find tracks before we even become sick. So our vision, grand vision, is that we would have those signals at the so early stage that we don't even need the medicines, but maybe we can change our lifestyles to avoid becoming sick or having these disease areas. Another on the individual level that we are also working on is women's health. I think just like Axel showed, it's typical with these clinical trials that women or other groups are underrepresented. The Swedish Prime Minister said recently that we should improve the Swedish healthcare system for women and young girls. And endometriosis is one of these areas that we would like to address. It's underdiagnosed, the diagnosis comes in very late, and the treatment is insufficient. So here we are working together with clinicians from Umeå Hospital and tumor surgeons there to hopefully improve that. On the societal level, what can we do there? Well, we want to take the knowledge that we can generate from the molecular and individual level to build in when we plan for the future planning of cities, workplaces, living environments. How can we do that? So here we are having designers, architects working on how can they plan for new city planning. For instance, up north where they are planning, maybe you've heard about the green transition, and 100,000 people are supposed to move up to northern part of Sweden. So there needs to be more living and workplaces planned for. And why not build in this health promotion at that early stage? So now, before Christmas, we will inaugurate Sweden's first graduate or research school in precision health with these PhD projects that I showed before. These are the leaders for this research school. And when I also would like to connect to Axel's previous talk and finish off, if we look a little bit to the future, what can we do next? I agree that data is king, in a sense, but how can we use that? How can we access it? Again, going back to the US, in parallel when Barack Obama launched this precision medicine initiative, NIH in the US also launched this All of Us research program, where they encouraged US citizens to share their data about themselves, not only when they are sick from medical records, but about their daily lives, nutrition, how they exercise, and so on. And this has been going on. There was a conference this spring where researchers now start to make benefit from all this data. In Europe, something similar is happening. Maybe you've heard about this European health data space. There's a lot of now investigation to see how health data from apps from different member states, from nationalities and citizens can come together in this data space or pool. And in Sweden, there are ongoing investigations about Hälso data and how we can make benefit out of that. And I think for us, working in precision health, where we develop new methodologies, this will become key for us also in the future. So with that, I thank you so much. If you're interested, please go into our webpage and you can read more about precision health. Thank you.
Thank you both for everything but giving me time to ask all these questions I have written down here. But we'll take that another fora if we can't manage it. Fredrik, first, what will you do with the information that you will get Alzheimer's in 20 years?
What I would do?
If you got that information now.
Well,
because right now we don't really have the treatments.
Exactly. I think it's a very valid question, because it's like chicken and egg. If you do know, what would you do if there is no treatment? But again, well, I would be encouraged, because then I would go to my lab with my coworkers and work even harder. But that's me. I mean, I'm a researcher. If you're any person in the village, would you like to know that, or would you rather live without knowing it? I would say that, of course, it depends on what kind of person you are. But again, knowing now that we did not expect the coronavirus to be spread, and the biologics that we developed and were able to, in such a short period of time, to treat that, I think that's encouraging. And again, this All of Us, the US program, where we share our information, is conforming. I think people, if we inform them that now you know that you have it, please share with us your data, your background, maybe your biological samples, so we can speed up. That's the way I see it.
Yeah, but it's a hard question. That's why.
It is.
Yeah. But I also, sorry, but I think that there is also the answer between is precision health and person-centered care the same? It's not, but they need to be combined. And I still haven't seen any research proposal or research project where we really try to combine precision health with person-centered care, because every treatment will have side effects, every treatment needs to be adapted to the person's resources and needs. And so I would like to invite you and to maybe we should do it together, but I think the combination is the key here.
Yeah. Definitely. Are we doing this fast enough? Because some of the things you said, we have been talking about that for a while, that we are slightly not as proactive as we would like to be. We focus more on health rather than being proactive. And when you talk about AI, I hear a lot of good things that we should do, but there's a lot of warnings. Are we doing this fast enough? You can start with AI.
Yeah, it depends on. I think like I showed, it's a balance between underuse and overuse. Yeah. So in that sense, we need to understand how to optimize it. I would say in many aspects we are a little bit too fast because we forgot, in healthcare at least, that we need to have evidence, because we need to be evidence-based. In that sense, you need to have good trials. You need to also know the implementation of it. And in many medtech companies, for example, the new MDR regulation will be a huge challenge, because I would say that pharma is more into the understanding about how you do a trial and the different phases, but we haven't had that so long in medtech. So I think that when we have the MDRs in place and we are starting to say that we need to have solid evidence, then maybe we are on the right track. But it needs to take some time in that sense.
So you think we are a little too fast, and I think we're a little too slow. What do you say, Fredrik?
Well, I just wanted to add on to your first question, because there was one thing I maybe didn't express enough, is that if you would say to me that you were able to look into my brain or measure something in my saliva and so on, it's not binary. It's not like you are saying, I'm having Alzheimer's or Parkinson. You maybe will have the risk to develop this in the future. And I think this is also encouraging for us. The earlier we can come in, the more I can feel I can be empowered to make the change myself. So I don't sit there and be reactive. I think that's sort of the strength here. And that's also where I see where, again, I totally agree that person-centered care and precision health should sort of somehow make the best use of it. We are trying to come in the very early stages. I think with primary health care, they do know more about, they interact more with people and these sort of soft values. Maybe we can make more use of them in precision health. So we can save sort of the specialized care for the later stages where you actually need to be treated or diagnosed.
Yes, I would also like to know that. So it's not, it's just what do you do with the information?
Yes.
Now I have a red timer there. That's usually a bad sign, isn't it? I would like to thank you all for this discussion, and I encourage you to discuss more at the lunch and in other forums, I guess. You had a couple of outreached hands to actually do more within the area and take them and do something good with it. Thanks a lot for this, and have a good lunch.
Thank you.